Okay, recording. So diabetes is unfortunately very prevalent in our pediatric population, more so type 1, but unfortunately with the rise of pediatric obesity and all of the other comorbidities that we're seeing start to manifest in kids, whereas they didn't so much, it was more so adult things. We do see type 2 pop up more frequently now as well, but most of the time it's going to be insulin dependent, type 1. So if you haven't gotten a chance to listen to the recorded slides prior to this one on the PowerPoint, please do so. If you didn't get to yet. Is there a question? I don't know if one of the other campuses, will you make sure your mic is muted? Thank you. If you haven't gotten the chance, don't worry. It's all really just like diabetes review. So just check that out whenever you can. So we'll start here today. This is slide 8 on the diabetes PowerPoint. So one thing that we definitely do, I feel like they should do, or adults should do, but things are a little bit more individualized when we're talking about pediatric diabetes because they're tinier and they're typically more sensitive to insulin. They haven't had a lifetime of resistance to build up to insulin. Their tissues haven't had a lifetime of resistance to build up to. And so typically we do things a bit more specific with them. So we'll talk about counting carbs, covering carb intake, and then correcting hyperglycemia. So lots of C's there. So counting carbs. All diabetics should do this, but it's definitely important with the kiddos. So typically when we're talking about counting carbs, 1 carb equals 15 grams of carbohydrate. So when you look at a nutrition label, flip it to the back and it tells you how many, like grams of carbs, and you get really upset because it's delicious, but it's like, 40 carbs and you hate that. But we're going to eat it anyway. But so 1 carb equals 15 grams of carbohydrates. And so this is going to come into play whenever we're doing the math to cover the carbs that the patient's eating. So, and then 1 unit of insulin typically covers 1 carb. So meaning 1 unit of insulin covers 15 grams of carbohydrates. I do believe your book says like 1 unit of insulin can cover between like 10 to 15 grams. I will specify on the exam if I'm going to have you like math and calculate stuff out. And that just kind of reflects to certain patients, especially like a new diagnosed diabetic, is going to be a lot more sensitive to insulin than the 60-year-old who has just been non-compliant for their entire life, right? They're going to require a lot more insulin. So some patients, we might give them 1 unit and it covers their carb intake a whole lot better because their tissues are more sensitive. Whereas another patient, might not be. And we typically see them be a lot more sensitive earlier in their disease process than we do later. So does that make sense? 1 carb equals 15 grams and 1 unit covers 1 carb. Okay. And so typically whenever we are taking care of a diabetic, we're going to count their carbs, right? And we're going to cover the carbs that they eat, but we also want to correct their hyperglycemia. So this is, typically your orders are going to read, check blood sugar, AC, and typically baseline AC and HS, right? So before meals and at bedtime, kids, a lot of the times if you work night shift, inpatient, you're going to check it between like 1 and 3 a.m. as well, just because those weird like drops, the, smoky effect and the dawn phenomenon and all that good stuff that you guys have learned about. But at baseline, we're doing ACHS. So why do we check AC? To see if they're hyperglycemic at baseline, right? Like we need to know what we're dealing with before they even take any carbs in. Because we need, if they're hyperglycemic, if they're running 200 before we even give them pancakes for breakfast, then we need to know that. And we're going to have to take that into account whenever we give them their insulin. So we also want to correct hyperglycemia. So that's why we check the sugar before. And then we give them their tray. They're going to eat breakfast. Do we just go ahead and like, okay, you have 60 grams of carbs on your tray. I'm going to cover you for all 60 of those grams. No, what if they don't eat that much, right? Like an adult, you might could get away with that, but a kid not so much, especially a small kid. So, we're going to check their sugar, then give them their tray. We need to know at baseline how many carbs were on their tray, right? So we typically count the carbs before we give them their tray. And if I ask you to do this on exam, I will give you all the necessary information you need. Like you don't need to memorize like how many grams of carbs in a piece of toast. Please don't do that. I will give you a chart for you to reference all the things. So then we have to know at baseline how many carbs are were they presented with, and then we need to know like how many did they eat. And sometimes it's a little bit of a guesstimate game. You're like, well, you might have eaten like half of that pancake. So it's not an exact science, but we definitely want to be as close, as specific as possible as we can. And then those two values we're going to add together because we don't want to check their sugar and correct hyperglycemia and give them an injection. And then, 30 to 45 minutes later, okay, you're finished with your breakfast. We're going to go give you another shot. That's mean, right? Like that's mean. We don't want to do that. If they have a pump, that's great. We can just program it in their pump. But if we're, like old fashioned giving insulin injections, we're going to combine the correction and the covering insulin and give it in one injection. Okay. So let's practice a little bit. So let's say our kiddo ate one piece of toast. And so our little reference tells us that one piece of toast is 1 carb, so 15 grams. They also ate a banana, which is 2 carbs, equaling a total of 30 grams. Sugar-free peanut butter is free because it's sugar-free. So 0 carbs there. And then 8 ounces of milk is 1 carb. So all in all, how many grams of carbohydrates did our patient eat? Right, so 60 grams, 60 grams. So four carbs, quote unquote, right? So that's going to require, if 1 unit of insulin covers 1 carb and they ate 4 carbs, then that's going to be 4 units of insulin that they're going to need to cover the carbs that they ate, right? And you're going to hear us say that, especially with kids, because like I would straight up die if I was a diabetic. I like sugar too much. I pray that's never something I have to deal with. But then also, and I think I talk about this in the recording, I have a 3.5-year-old. There's a laundry list of things I would rather do than have to restrict his carb intake. Like it gets very difficult. And until a certain developmental level, we kind of run on the general thing of, yes, well-rounded diet, but a picky toddler is a picky toddler. And a diagnosis of diabetes is not going to change that. If anything, it might make it worse. Because we're just going to exercise all of the independence that we can and the control that we can. So kind of we rely on just make sure it's covered, like, yes, try to get them to eat as healthy as you can, restrict carbs. But that's hard to do as well, right? Because we still have growth and development milestones that we need to meet. Like we still need to grow and gain weight and all the things. And carbs is one of the big ways that, healthy carbs is one of the big ways that kids are going to do that. And so, kind of the motto is like, as long as it's covered, just make sure it's covered. Eventually we get to the point where they do take more of an independent role in their disease process. And, hopefully they will want to count their carbs and they will want to take care of themselves. But a 3-year-old doesn't understand that. They just understand, I want a pancake and you're not giving it to me. And I'm going to throw a royal fit about that. So, when we can do sugar-free syrup, that's great. Modify the things that we can modify, cover for the things that we can't. All right, so we said we needed 4 units of insulin to cover our carb intake for breakfast. But when we checked their sugar before breakfast, let's say it was 300. So we also need to correct our hyperglycemia. Typically, and this is very patient-specific, patient individualized as well, because it's all about insulin sensitivity. You're going to have kind of this equation in your orders. And so it's basically going to say you're going to give a certain number of units of insulin per a certain number of milligrams per deciliter. So a certain, blood sugar points, if you will, over a certain blood sugar. So that probably sounds very hairy. I don't mean for it to. Let's put actual numbers in there. So if our order would say give 1 unit of insulin per 50 over 200. So with a blood sugar of 300, we need to give 2 units, right? Because 300 is 100 over 200. So you're covering whatever your blood sugar is over 200 milligrams per deciliter. You have to cover for that excess by giving 1 unit of insulin per 50 milligrams per deciliter over 200. So if we had to give 4, let me get a pointer going. Here we go. All right, now we're good. All right, so if we had to give 4 units of insulin to cover our carb intake over here, and then we checked our sugar, it was 300. Our orders tell us for this specific patient, give 1 unit of insulin per 50 over 200. We would give 2 units over here. So all in all, we are giving 4 units plus 2 units to correct and cover. So 6 units total.
Will we give that all at the same time?
Yes, you will give that all at the same time. Because again, we don't want to be mean. Like, I don't want to give you 2 injections. I don't want you to give me 2 injections. Like, I'm going to throw a fit as an adult. A kid definitely will. And this is a very difficult disease process to have as a child. It's a difficult disease process. How compliant are your adult diabetics that you take care of?
Not at all.
Not, right? Like, not at all, because it sucks, right? Like, it sucks to have to give yourself injections. It sucks to have to, poke your finger however many times a day. And that's why we love the technology. Like, we love the Dexcoms. We love the insulin pumps. It's made it so much easier to be more compliant, especially when you're talking about pediatric diabetics. Because like I said, there's a long laundry list of things I would rather do than have to poke my kids upwards of, probably minimum 6 times a day. Like, that's terrible. Okay, any questions on the other campuses? I do have extra practice of this on Moodle if it's not super driving in your brain right now. And of course, reach out to me if you need help. Okay, so also question, do we need to cover protein? No. Do we cover fat?
Yes. Right.
No, we only cover carbs. Now,
carbs.
Do we just yes, eat all of the fat that you want? No, we still want to promote well-balanced diet, right? But we cover carbs because carbs are sugar, right? Protein, fat is not sugar. Chemically, molecularly, it's not made up the same. We don't cover protein. We don't cover fat. Okay, DKA. DKA season is typically over the summer, or when kids go on break from school, because the school nurses are not on top of them to take all of their their insulin like they should be. And then summer, they're home eating all the junk food, playing outside in the hot heat, getting dehydrated. So you might not see that many cases in PICU this fall for clinical, and then in the spring. But DK is absolutely huge in the pediatric population. And a lot of times we'll see them we'll see them on that initial diagnosis, because nobody knew. It's one of those things you don't know till you know. And they'll come in DK, and that's how we find out that, oh, hey, you're a diabetic. And then they kind of go through this long stretch where they're managed pretty well, as depending on what age they're diagnosed. But then once they hit adolescence, it's like a revolving door, because they're over it. They don't want to be a diabetic anymore. They don't want to check their sugar. They don't want to count their carbs. They don't want to be different from everybody. And so, we can keep it pretty well managed at school, because if you've got a good school nurse, they're on top of them, have them under a microscope. But when school nurses, out of the question, it kind of all goes haywire. And I love when they're honest about it. I remember one time admitting a diabetic, and she was like, it was prom, and I didn't want to wear my pump. I wanted to be like everybody else for the night. The sugar popped off. And I was like, you know what? I borderline can't even be mad at you about, at least you're honest. At least you're honest. So it is very difficult for them. And we do see them come in like a revolving door once they hit adolescence, because they don't foresee the long-term negative effects of it. And they just want to be like everybody else. So I know you guys have gone over DKA to some extent. In second level, you'll go over it again in fourth level. It's very, very common though. So our causes here, overall, just a lack of insulin. So hyperglycemia and relative lack of insulin. So either like the little, the teenage girl, I took my pump off. That's pretty common. So no insulin there, right? Or a lot of the times, more so what it is that stress response. So they got sick, or like some stressful event in their life happened. And so remember, part of that stress response is the body secretes cortisol and, norepinephrine, epinephrine, all these things that mobilize glucose in our body as part of that fight or flight response. And so we've got that hyperglycemia there, and maybe, they stopped taking their insulin because they were sick, and they didn't realize, like, I probably needed more insulin, but I stopped taking it altogether. Or they did everything perfect and it just still happens. Like, it's just one of those things. Sometimes you can do everything perfect and they'll still go into decay. Our presentation is pretty variable. There's a box in your book, 10.5, that goes over the different, assessment things that you'll see. I've seen them, come in just a little bit tachypnic or otherwise pretty common, but their labs are terrible. On the other side of the spectrum, they come in a full-blown coma, and we have to intubate them because their airway is not protected. They're so neurologically not intact at that point because they're so acidotic, they're so dehydrated, they will not protect their own airway, and we have to go ahead and intubate them. Typically, it's not an intubation situation. Respiratory wise, they can look very scary because they're Kussmauling, right? And they're, just huffing and puffing, trying to breathe off all of that excess CO2 to bring their pH back where it's supposed to be. And so it can be a very scary situation, especially if you've never seen, them coming Kussmauling very severely. But it's not a respiratory problem, right? It's a metabolic problem. And once you start correcting that metabolic problem, the respiratory symptoms will calm down and everything will fall back in place. So typically it's not an intubation situation, but for neurological protection, it absolutely can be in very severe cases. So neurologically, like I said, they can be very altered just because they're very dehydrated. Typically a DKA comes in and they've lost at least 10% of their body weight in water or in fluid, just from the diuresis, just from the tachypnea. So they're very severely dehydrated at baseline when they come in. Also very acidotic, and our brains, our central nervous system does not like whenever we're acidotic, so they can be very altered. They'll typically have a history of nausea and vomiting from the acidosis, also from the dehydration, and then, if maybe it was a stomach bug that brought them in, but you'll frequently see, nausea, vomiting, and then abdominal pain as well. How do we think their heart rate will be?
Trying to compensate.
Right, so super tachycardic, right? Super tachycardic, they've lost upwards of 10%, most of the time, at least minimum 10% of their, don't be on a timer, of their body weight just in fluid. So yes, very tachycardic. We talked about the Kussmaul's. pH-wise, they're typically very acidotic. And so, one of the compensatory mechanisms that our body does is makes you tachypnic, right, to blow off CO2. CO2 acts as an acid in our body. And so trying to blow off the CO2 via, that respiratory compensatory mechanism, because respiratory acts a lot quicker than the renal compensating mechanisms, right? So yes, typically very tachypnic, those Kussmaul's respirations, huffing and puffing. The acetone breath, that's kind of like a hallmark, but I will tell you, I think I've only actually smelled it like once or twice, unfortunately. Like that was something I was really excited to be able to, experience. And I have, but it's not like opening a bottle of nail polish remover, unfortunately. It can be kind of subtle. And then overall, how do we think their perfusion is going to look?
Probably poor.
Terrible. Absolutely terrible. Blood pressure low, cap refills delayed, pulses are just, very, very poor. Circulatory wise and perfusion wise, we're very, very altered because we're very dehydrated and we're very acidotic. And that alters our heart muscles. And our heart cells want pretty pH. You'll learn that in 4th level. Cardiac function is very, very poor when we're looking at our patient being very acidotic. That's one of the reasons we'll try to correct pH if we're in an emergent situation and we're trying to give, like emergent vasopressor medications or epinephrine and stuff like that. We have to correct the pH as well because we can give all these other things, but the heart might not respond to it as effectively because we're so acidotic. So perfusion, very, very poor. And then blood pressure can be in the toilet. I've seen DKs have to be put on vasopressors because their blood pressure is so low, between the volume loss and then just their heart not responding well to anything because they're so acidotic. So it can be very, very, very severe. So urine output, what do we think that's going to look like?
Probably not good if they're
Not good. Yeah, not good. Very dehydrated. This is actually a really big thing because we're going to talk about electrolyte abnormalities, and a big thing we're going to do is give potassium. And usually we always want to make sure that we have good urine output, right? The kidneys are functioning before we're given potassium. So that's a very big thing that we have to keep in mind because we're going to have sometimes very severe, very dangerous potassium abnormalities with this patient, but they might not be urinating. So we kind of can get in a sticky situation there. So lab-wise, specifically like diagnostic-wise, blood sugar greater than 250, frequently much higher than that. I've seen like 13 and 1400.
oh my God.
Yeah, she was definitely intubated.
I
pH less than 7.3. That's going to vary with severity. I've seen like 6.8. That's fun. Bicarb is typically low. That's going to vary with severity. And why is our bicarb low? Because we're acidotic, and so like all the bicarb has been used up, right? Because bicarb is a base. And so it's trying to bind with all of the acids, the metabolic acids, and so it's being used up and it's not being replenished fast enough by the kidneys or reabsorbed fast enough by the kidneys. All right, and then kind of to the right of bicarb, you see GAP. So do we remember learning about like anion gap? Does that mean anything to us? So anion gap is basically a way to measure how acidotic your patient is. So this is a situation where we have a elevated anion gap because our patient is very, very acidotic. These are all things that we're looking at and the provider is looking at once we start intervening, all of these numbers to come back within, normal limits. And that's how we know we fixed the patient. Fixed. Ketonuria, they're going to have massive ketones in their urine, massive ketones in their blood typically. Electrolytes can be super variable depending on where you catch them in this process. So, I don't want you to get in the weeds about, like, will the potassium be high or low? Depending where you catch them, it might be through the roof or because of the shifting, because remember, potassium is positively charged, right? Okay, I don't want to blow your mind with this. Potassium is positively charged. So are hydrogen ions, right? So remember when we learned in patho, they're going to do the flip-flop, right? Like they're going to flip. Potassium's typically in the cell. Well, when we have an acidotic situation, it jumps out so that hydrogen ions can jump in to try to offset that acidosis. So, initially we might be super hyperkalemic because of that jumping, but then once we start peeing everything out with the diuresis phase that we're going to see, they might lose most of their potassium in their urine. So really just depends. I'm happy if electrolytes are a problem in DK. We monitor them very, very frequently. We can have very serious, very dangerous potassium abnormalities.
So you got to monitor their heart pretty close.
Absolutely. This is a PICU patient. If for nothing else, then continuous cardiac monitoring and telemetry. BUN, what do we think that's going to do? If we're stupid dehydrated.
Probably go down.
Go up, right? Yep. It's going to go up. Creatinine probably too. Very, very common to see acute kidney injury in a DK just because of the sheer severity of dehydration that we see. So management, what do we do? Cute little mnemonic, HIE. So we are going to rehydrate. Typically we see, hopefully the ER will give them a bolus. And then once that bolus is finished, we start them on an insulin drip. Let's think critically. Why might I not want to do those at the same time? Like, why can't I just run the bolus and, like, let's start them on insulin now?
The insulin's gonna do like the wonky stuff with the fluid, right? Because that's kind of why I don't want to give it like with kidney patients sometimes, like to do like the. And
If you're giving glucose over a long time, it's gonna like slowly bring down the blood sugar.
Okay. So I had someone say if you give insulin over, like are you meaning like in a controlled way, it's going to bring it down? If I give them a bolus of fluid, what's it going to do to their blood? It dilutes it. So what's that going to do naturally to their sugar?
yeah, probably drop it.
It's going to bring it down, right? So if I bolus you with a liter, that's going to drop you. If I bolus you and then also give you insulin, it's going to drop you like probably twice as fast, right? So big thing you need to think of with DK is all the osmotic gradients, like the osmotic concentration of the blood versus the osmotic, concentration of the cells, especially in the brain. We can absolutely kill a DK with like fluid shifting in and out of their brain, like huge safety thing there. So, like we talked about, I think somewhere on here I have, our goal usually is to only drop their blood sugar by like 70 to 100 milligrams per deciliter per hour. So if we're dropping like 200 and 300 blood sugar points, if you will, per hour, that's a problem because I'm too rapidly changing the fluid concentrations of like blood versus brain cells. And I can cause their brain to swell and basically cause them to be brain dead. So not to freak you out, not to, scare you, but this is why it's an ICU patient. It's a very controlled situation. So yes, bolus. And then we'll start an insulin drip. This is IV. So when I say insulin drip, IV insulin, what is the only insulin I can give IV? Regular. What is the only insulin I can give IV?
Regular.
What is the only insulin I can give IV? Regular. Think that'll be on the test?
Yeah.
I said it 3 times, but it's still a mistake made in practice. Only insulin you can give IV is regular. Electrolyte replacement, variable, right? Because our electrolytes are variable. So this is a very frustrating patient because you're like constantly changing your fluid bags, constantly. Because you're getting labs like every 2 to 4 hours. And things are changing because hopefully we're fixing things, right? So a lot of times we'll have to replace potassium and phosphate. Usually expect those in your fluids. So as we start to bring our patient's sugar down, once they start to hit like 250 to 300 on their blood sugar, we want to start anticipating putting dextrose in their fluids. And that might seem counterintuitive, but what is my patient at massive risk for being on a continuous IV insulin drip?
Really low blood sugar.
Hypoglycemia. Hypoglycemia is very dangerous, right? More so than hyperglycemia because the brain can only use sugar for energy. Only use sugar for energy. So if we have no sugar, the brain cannot work, will not work. Brain cells will die. So we want to anticipate adding some dextrose to our fluids as our sugar starts to come down to 250 to 300. Q1 hour neuro, at minimum, Q1 hour neuro and blood sugar checks. Sometimes it's Q 30 minutes. This is a very busy patient. You don't want to have 2 DKs at the same time. We talked about the continuous cardiac monitoring. We're getting blood pressure at least every hour, if not more frequently, when they're very, very fresh, kind of labile. Very astute assessment, especially neurologic wise. So like when I say Q1 hour neuros, I'm talking like you're checking pupils, at that frequency. Like you're getting, are they awake or oriented? Like what is their level of consciousness? Do they respond to pain? Do they only respond to this? Like all of those details that you learned about and what is it, 30/60? Yes. Yes, 30/60. Like we're being that detailed every single 30 minutes or every single hour. And if things start to look wonky, we're letting the provider know. Not uncommon to have to go on a field trip to CT with a DK because, very low threshold of are we having brain swelling? Like very low threshold. Do we need to do like bigger interventions to prevent brain swelling and brain herniation, right? Because it's pretty much game over at that point. And it's a very real, very scary complication that we face with this. Strict I's and O's for obvious reasons. A lot of the times, they don't automatically get a Foley, but a lot of times they're so neurologically out of it, it's not safe necessarily for them to like get up to a bedside commode, and they might not even be wicked enough, to really participate enough for you to put them on a bedpan. So frequently you will see them have Foleys. And then kind of provider preference, whether or not they're NPO. If we're not worried about them vomiting and aspirating, some doctors will let them eat and or drink while they're on the insulin drip because they're covered, right? Others, not so much. They'll starve them. But very, kind of provider preference, and then very, like just dependent on the patient and the situation as well. And then, of course, prevention is key. Education is huge. This is where sick day rules come in like really, really big, just because, a lot of times parents will think, oh, my kid's vomiting, they don't need insulin. Super not true. Like you need to be checking sugar more closely for sure, but they might actually need more insulin because of that stress response. Okay, so hypoglycemia is not a new thing to you guys. But our little nuggets are much more at risk for it, right? They don't have like the same fat composition we do to pull. They don't have all the glycogen reserves in their liver and in their muscles like we do. So they don't have the sugar reserve if they're NPO for a prolonged period of time or whatever may have you. So hypoglycemia is going to be defined as a sugar less than 70. Your book says 54. Question mark. I super don't love 54. So we're gonna, 70. 70, most hospital policies are gonna have you start intervening at 70. So 70. Obviously your first intervention, if your patient is, experiencing symptoms of hypoglycemia, if you can, check their sugar, right? But if you can't, a symptomatic diabetic, symptomatic, really just patient where it could be hypoglycemia, they're hypoglycemic until proven otherwise. And so we're going to treat, even if we can't check, we're going to treat because like I said, hypoglycemia is going to kill you a whole lot faster than hyperglycemia will. Like if you're hyperglycemic and I give you some juice, like what happened? I just made you more hyperglycemic. Okay, great. Who cares? Not who cares, but yes, you can definitely go into DK, but that's going to take a longer amount of time than hypoglycemia, damaging your brain. So if you can check. If not, treat. So how do we treat? How do we treat hypoglycemia? Okay, so yeah, oral, right. If not neurologically altered, we can do PO. A couple ounces of juice. Always want to give them like a little protein snack after to keep them from rebounding and dropping again.
If they are NPO, would it be like a D50?
Right. So if neurologically altered or NPO, that's always why I just by the by. If patients NPO, adults not so much. Kids, babies for sure. Kids definitely. If we're NPO, advocate for dextrose fluids. Or you're going to have a hypoglycemia situation that's just asking for trouble. So yes, if neurologically altered or NPO, then and all diabetics should have typically standing orders, right? Like for a lot of places will do the glucose gel where you can just like rub it, on their gums. A lot of nurseries are actually going to that now, doing that instead of like having to reach for formula for a breastfed baby. But yeah, so that's going to be like you're going to reach for D25 or D50. So typically we don't like to give like more than, like D12.5 in a peripheral vein, but this is an emergent situation, right? Like risk versus benefit. We need to get their sugar up. So yeah, that's when you'll reach, and give them a dose of D25 or D50 to bring it up. Or, typically you'll have standing orders for IM glucagon as well. And diabetics, so like just like a anaphylactic patient or allergy patient has an EpiPen, a lot of diabetics nowadays, they'll have a glucagon pen as well. So that's good. And I think someone was telling me the other day, they're actually doing kind of like the intranasal Narcan, like there's a intranasal glucagon now. So that's great. Like constantly just coming out with, things to help prevent and treat complications. So that's wonderful. So yes, if unconscious or there's airway compromise, we obviously don't want to put anything in their mouth, right? Like that's just going to add insult to injury. And if we've had a hypoglycemic event, we want to make sure we get them on dextrose like maintenance IV fluids after, and so we can get everything regulated, right? Or we'll just be chasing our tail. Okay. So let's move on to the other endocrine one. So your book, I'll preface to say, your book goes over a lot of endocrine conditions. If I don't cover it, like in lecture today, if it's not on the PowerPoint, I won't test you on it. That doesn't necessarily mean that it's not seen in pediatrics. It's just like you've already learned about hyperthyroidism, right? You've already learned to some extent about like diabetes insipidus, SIADH. If not, you'll learn more about it in 4th level. So these are all things that we can and do see in pediatric patients. Just for time's sake, like I don't have time to re-lecture 400 million things. So without further ado. So endocrine system is responsible for a lot of things. It's got all the same components that we have as adults. If you need to review your A&P, of course, feel free to do so. You've got some great charts in your book, great little boxes. The difference is the gonads will develop over time. So eggs are present and accounted for at birth within, a little female baby's ovaries. But sperm's not produced until puberty. So there's a difference there. And remember that hormones are the chemical messengers that control our cells and their functions. I'm always like massively impressed, and I have mad respect for endocrinologists just because the endocrine system is so complex, so intricate. All the feedback mechanisms really they just blow my mind. It's just very complicated and complex. So we have problems when there's too much or too little of a hormone. It's kind of like the mainstay of our endocrine disorders, right? Typically we have one variation that there's too much of the hormone, or a variation on the opposite end of the spectrum where there's not enough of it. And with these, we can see a lot of like growth and development abnormalities, intellectual delays, and even death. So responsibilities of the endocrine system, sexual differentiation during fetal development. So is this a boy baby or a girl baby? That's all under, like obviously it's genetics as well, but the actual development of the genitalia is very much like hormonally controlled. And so we can see in certain syndromes, and Dr. Wood, when she goes over some genetic stuff later, and not, I think maybe next week, she'll talk about like Turner syndrome and some other syndromes where there's extra chromosomes or things just didn't quite line up the way they were supposed to be. And so we can see like external sex organs are abnormal because of that. And so I'll touch on one thing. It's called ambiguous genitalia. But this is one of the things that we can see with hormone abnormalities is that, external genitalia of the patient is not very clear as to whether they're a boy or a girl. Also responsible for stimulating growth and development during childhood and adolescence. So we'll talk about growth hormone deficiency. That's going to be one of the main hormone that's at play there. And we talked about development of the reproductive system in utero, triggering our beloved puberty. So we have our, the sex organs secrete testosterone and estrogen and all those wonderful hormones. And so when we can see, something called precocious puberty, where puberty starts way, way sooner than we would normally expect it to, or delayed puberty, where it hasn't started and it really should have. Table 32.1 in your book goes over all the endocrine glands and the hormones and their functions if you need to review those. And then there's a little general nursing intervention, section of your book. As usual, be sure it's all, mostly like fundamental kind of common sense stuff, but make sure you, you check that out. Okay, so just quickly, ambiguous genitalia. I just want to cover this just because it is something that we see, and I don't ever want you to be like shocked by something. And there's a good picture in your book, 32.4. So with that picture, it's in relation to congenital adrenal hyperplasia. So with that one, like the ambiguous genitalia is secondary to, endocrine condition. We can also see it as a side effect of some medications. I think we've actually, seen that in clinical this semester where, a patient was maybe on certain seizure medications and, they were 4 or 5 but they had pubic hair. And so that can be, side effect of medications, but then also, if we have some massive neurological insult, pituitary is what controls, that's the controller of most of our endocrine function, the other endocrine organs. And so when we see abnormalities in the brain, we can also see them manifest as, signs of endocrine abnormalities as well. So with this, we can also see it from like an error or abnormal sexual differentiation. So with this, you can see on the left, normal female, reproductive anatomy. On the right, that's also a female. Doesn't look that way, right? So if you get a newborn and this is what you're looking at on the right, you would feel safe to assume boy, right? But not so much. And so in this instance, we have to do like genetic karyotyping to definitively determine, what the actual sex of the patient is. And obviously, huge thing, psychological counseling, right? This is a little bit, traumatic for parents. Like, wait, I thought I was having a girl baby. Why do I see these parts? I thought I was having a girl baby. So psychological aspect is very, very huge for family and patient. And then also just by the by, precocious puberty. So appearance of secondary sex characteristics before they should appear. And the age is going to differ depending on the gender. Typically girls hit puberty before boys do. So, you don't have to know specifics there, but just, hopefully the picture will drive it home for you. And at the end of the day, big thing is if you're seeing, signs of puberty before you should be, we need to make sure that kiddo has an endo referral. That's really the biggest thing there. Okay, growth hormone deficiency. So our etiology here, there's lots of different ones. So it can be damage to the pituitary. Like I said, if you've got shaken baby syndrome, if you've got a kid who had just like massive head trauma, things like that. Or, we had a little nugget yesterday who had, in clinical, lots of brain abnormalities. So like I said, very common to see those occur together just because of the pituitary is in the brain. So, damage to the brain. We can see genetic or familial linkages here. It can be, maybe part of certain genetic syndromes, things like that. And then also just psychosocial deprivation. We also had an instance in clinical this week with a neglect case, failure to thrive case. And, obviously with that, it was physical neglect as well. But just, psychosocial deprivation can also manifest as, growth hormone abnormalities, and it can negatively affect their physical growth and development. Patho, overall, we have a lack of growth hormone. So we don't get all the, stimulation of protein synthesis and cell growth, which translates to human growth. Because we are cells, right? You're just a big old pile of cells. Typically, clinical manifestation wise, these kiddos are usually like normal weight, normal height at birth. There's no big alarm there. But they start to fall off the growth chart. Typically by the time they're like 1 year old, we can't really even plot them on the growth chart anymore. They're so, their weight is so low for, their height, and their, height is so short for their age. They don't fall into any percentile. They're completely, falling off the growth chart. We can also see seizures, mostly from hypoglycemia, just because that's one of the big jobs of growth hormone. It interacts with, and like talks with, insulin-like growth factors, and make sure that we have enough, mobilized glucose for our cells to do the things that they need to do. So we can see hypoglycemic seizures, hyponatremia, especially in light of pituitary damage. We can see something called micropenis, which is where, obviously, little boys' reproductive parts are abnormally very small. Just very, very we can't even do a circumcision, just very, very small in relation to what it should be at that age. The testes will also frequently be undescended. So that's called cryptorchidism. So if something's cryptic, it's like hidden, right? So cryptorchidism, I think Ms. Harrell talked about that with GU. Do you remember how many months old, if the testes are not descended at birth, how long do we give them?
Yeah, like 6 months.
Right, like usually around the 4-month mark. If they're not trying to make their way down, then that's a problem. So, but, at this point, with growth hormone deficiency, we're past that point. They're not, we're 4 months, 6 months, they haven't descended. They appear very cherubic. I have a picture of cute little nugget on the next slide. So you think a cherub is
like cute.
Yeah, like cute. The little like Christmas angels with the like little bubble butt cheeks that are like just really cute and baby like. That's a cherub. So they're just very, very baby-fied. Very cute, very, very baby-fied. They don't like lose that baby face that you typically expect them to as they start to, grow up and get older.
So will this persist through puberty too? Or will like all those hormones help it?
It'll persist until we treat it. Yeah. Typically their voice is higher pitched just because when we hit puberty, that's one of those things, it's hormonally controlled, right? Their voice starts to do that super fun change. And then delayed dentition as well. And this can be very, very patient specific, right? I know like 2 of my kids started teething, I felt like at birth, and we're like hitting 1 year old, and I'm like, do you have teeth? Whereas, my middle kid, I feel like got 4 teeth overnight, never teethed once. So that can be very individualized. But if we're, we're a year old, 12, 13, 14 months old, we haven't gotten any teeth, we're looking at delayed dentition there, and that can be a sign of this as well. And then just overall decreased muscle mass, decreased skeletal growth, and we can see cognitive delays as well. So big thing here, any kid who's falling off the normal growth chart should be worked up, should be, referred to a pediatric endocrinologist. And they'll do, some diagnostic tests. They can, test their insulin-like growth factors. They can test their growth hormone levels. A lot of times they'll get an MRI of the brain just to rule out, any structural abnormality, make sure we're not dealing with any tumors or anything like that. And then we'll also see them get x-rays of the kiddo's hands to determine their bone age, which I have a picture on the next slide that kind of explains that. And with that, basically we're comparing their chronologic age, so per their birthday, how old they are, and comparing that to their bone age. So, you've ever heard the saying, like, your bones don't lie, like bones don't lie. So it's true, the bones should grow at a certain rate. And so if the bones are not growing at the same rate that they should in light of and in comparison to that child's chronological age, then that's another, check mark that we're potentially dealing with a growth hormone deficiency problem here. And like I said, CT, MRI, just to make sure, rule out any, tumors, brain tumors, or brain lesions that could be causing the problem. So our treatment, if they do determine that the levels of the hormones are deficient, is going to be growth hormone supplementation. And we do that with either IM or sub-Q injections 6 to 7 times a week until growth is complete, which is somewhere along the lines of 14 to 16 years old.
Repeat that.
So, sometimes for life. I sure can. So it's IM or sub-Q injections of growth hormone 6 to 7 times a week until growth is complete, which is normally, 14 to 16 years old, but sometimes it's required for life. And your book has the pharmacy 32.1 that goes over side effects and stuff like that, so be sure to check those out. Our management, we definitely want to monitor the kiddo's growth and development, right? And teach about med administration and side effects. The name of the medication is somatotropin. It can cause headache, which kind of makes sense, right? Like you're stimulating part of the brain, right? So makes sense, headache. Can cause hyperglycemia. And so with that, elevated A1C. And then just overall like arthralgia and myalgia. So think about like you're forcing a growth spurt, basically. So if you think about it like that, it kind of makes sense. I want to refer, for support if they need. This is a kiddo that, if they look different, they feel different, they are different. We have body image disturbances. They can deal with bullying at school. And we always want to treat them as their chronological age, not the age that they look like. Because kids are brutally honest if you haven't realized that yet. And a kid will tell you how it is real quick if they feel like you're babying them. So this is the picture. Look how cute he is. But that picture all the way to the left, he's 1 right there. Right, like he's so tiny, right? Like it looks like he could be like 3 or 4 months old right there. He's 1. And the middle picture, he's 2. whereas he probably looks more like, 18, maybe, 18 months old, maybe more so probably like, 12, 15 months old, and then 3 years old right here. So it looks like, they've started some treatment here. He's bulked up a little bit. He's not quite so cherubic, but you can see like his facial features, they like almost haven't changed at all, from this 1 year to 2 year. So really like infancy to, 2 years, he still maintained all that little cute little baby face. And then this picture on the right, where'd my pointer go? Oh, I switched PowerPoint, sorry. So the picture on the right, y'all can yell at me because I have two screens. So like I'm pointing over here, and if it's not showing over here, then it's useless. So picture over here on the right is the bone age. So you can see a newborn, cute little fat hands, but the bones are very, like they're shorter, right? They're more spaced out from each other. And then whereas as we grow and develop, those bones lengthen and, things are ossified, right? So like you can see like the orange is the ossification process. And so also I love this picture because it's a really great like pictorial representation of why we don't expect, a 12-month-old to be able to hold and write with a pen and stuff like that, as opposed to, a 5-year-old. Like, look how much more, like, you can see how much more manual dexterity they would have, just because of, the hand growth and the bone growth and the ossification process. But so they can do, these x-rays just to see, does the patient's bone age match up to their chronological age, or bone-wise, are we dealing more with, a 3-month-old when we should be looking more like this? All right, congenital hypothyroidism. Let's see, we've got congenital hypothyroidism and then inborn errors. And then we can take break. Okay, so our etiology here is we either have the thyroid gland either fails to develop or it's just not functioning properly, and so therefore we have decreased circulatory levels of thyroid hormone. This is the most common thyroid disorder in newborns and children. And it's a really big safety thing because it's the most common preventable cause of mental retardation in children. You'll find in OB, they take thyroid abnormalities, especially like hypothyroidism and stuff like that, very seriously in moms, because if we have thyroid abnormalities in mom, and that translates to, like lack of thyroid hormone in baby, like that's a really big deal because it can cause like irreversible, delays, irreversible brain damage. And of course we want to prevent that if we can. So we've got a partial or complete loss of function of the thyroid gland. It either fails to, develop or fails to function properly. Can result from maternal consumption of iodine or meds for hyperthyroidism during pregnancy. So think back to farm, that's your methimazole or your PTU, which is propylthiouracil, but you can call it PTU. But those are the hyperthyroid meds, right? So if we've got a mom with hyperthyroid and she's taking medication to get her thyroid to simmer down, that can translate to hypothyroidism in the baby, which is a problem. And so they'll monitor her, T3, T4s, all those things very, very frequently and very closely while she's pregnant. And then we also see a high correlation of this condition with Down syndrome. So this little nugget picture on the left, he looks like he could have Down syndrome maybe. He's cute, but he's got some very much characteristic. That tongue is very characteristic.
You said this comes from meds and increase in.
It can come from if a pregnant mom is taking medication for hyperthyroidism to bring her thyroid, like her T3, T4 down. Yeah. That can cause hypothyroidism in the baby. Yeah. So manifestations, typically there's no like overt signs at birth, which is kind of scary. Usually it'll start to manifest around 3 to 6 months old, sorry. And unfortunately, by that time, a lot of brain damage has already occurred. Thankfully, this is something we do what's called a newborn screen. You might hear it referred to as a PKU at some hospitals, but it's newborn screen, and they basically, do a heel stick on the baby and put their blood on this filter paper that gets sent to the state lab where they do a lot of additional testing on it. And it's basically a screening tool. It tests for a bunch of just like metabolic and endocrine stuff that can be very detrimental to brain growth and just, very life-threatening in general. So this is something that we test for on the newborn screen, but it's only a screening, right? And so there is always the issue that it doesn't screen positive when it should have. But beginning treatment within the first 2 weeks of life is very much preferred because that helps decrease the chance of permanent developmental devastation. I'm going to focus more so on like the manifestations in newborns and infants, just because that's really when we want to identify it, right? But it looks very much like hypothyroidism, just like you learned in adults. And so if you have a kiddo or an adolescent with hypothyroidism, it's going to look very similar to the way that it did in an adult. But in newborns and infants, a lot of times they're described as, oh, they're a great baby. They sleep all the time. They kind of suck at eating. Like they're kind of lazy when they eat, but like they're great. Like, they slept through the night. Kind of hard to wake them up sometimes, but I mean, you just don't hear a peep out of them. They're a great baby. So difficulty feeding, very sleepy. Sometimes they'll be described as floppy. I don't love anytime a patient is described as floppy. I do not love that. It's never normal. In some conditions, if that's the patient's baseline, if they're floppy at baseline, I'm better with that. But if they're not floppy at baseline, usually we move quickly when patients are floppy. So then as time goes on, they'll have delayed growth. If it doesn't get caught, they're going to fall behind meeting those developmental milestones. And with hypothyroidism, we see everything kind of slow down, right? So we can deal with constipation, even in infancy here. We can see bradycardia, or even just, like a lower baseline heart rate than what you would expect for a newborn. Hypothermia. Their fontanelles are typically larger. And we can see prolonged jaundice in the newborn period as well. Labs, usually we'll see a decreased T3 and T4 with an elevated TSH. Because remember, this is kind of like it's one of those feedback things, and it's kind of a multi-step process. Like one endocrine organ secretes the TSH, which tells another one, to make this. And so we've got this feedback mechanism where, we've got lots of thyroid stimulating hormone, but we've got a thyroid gland that isn't responding appropriately. So elevated TSH, that's not doing anything. So still low T3 and T4. And then we talked about the newborn screen. Hopefully they'll screen positive. And at that point, the state, that's like a critical result. The state calls the pediatrician's office, and, babies should be seen very frequently after birth, like all the time. But, again, there are kiddos that fall through the cracks. There are people who, don't bring their kiddos for their newborn checks. They don't, do this, they don't do that. And so it's not a perfect system, unfortunately. So treatment-wise, our clinical therapy goal is to restore and maintain that thyroid, the normal thyroid state. And we'll do this by giving levothyroxine or Synthroid. And this is forever, unfortunately. The pharmacy 32.2 in your book goes over this. Should be farm review. And just realize with kids, they grow, once we start giving this, they're going to grow fast, right? And everything's weight-based. So do we think we're going to stay on a constant dose for very long? No. We're probably constantly going to be changing the dose as they grow, which is good. We want them to grow. But those follow-up appointments are absolutely crucial because of that reason. It's going to be, we're going to be titrating up on that dosage frequently as they start to grow. And we can also see vitamin D supplementation given for bone health. And so this is actually something that I didn't know. So levothyroxine cannot be given with soy formula. And it also shouldn't be given in liquid form. So this is like a tablet that's going to have to be crushed. Like it's not, going to be, it's not going to come to you in a liquid form. It's not going to be supplied to the parents in a liquid form. It's going to be tablet form. And so the pill will have to be crushed, and it needs to be mixed with either human milk, so breast milk, or non-soy based formula. Soy products, and not just formula, like all soy-based products, block the absorption of Synthroid. And so that goes for your adult patients as well, just for fun, just extra. And so if we've got some kind of, and this becomes important because if you don't know, there are a lot of different formulas on the market. Like it's a little bit ridiculous. And some parents are very willy-nilly with like, oh, my baby spit up, or like, I feel like my baby's, super gassy, super fussy. And it's a very willy-nilly decision to like, let me just go reach on the Walmart shelf and try a different formula. Because, like somebody on this Facebook group or that Facebook group or whatever recommended it, when really it shouldn't be that way. It should be like, a conversation with the provider, the pediatrician, because we can have like serious repercussions. Not all formulas created equal, and the ones that are different for a reason. It's not just like your baby is gassy, they need to go straight to soy formula, right? They might be, but there's a stepwise process that we need to go through. And so, just it's kind of a safety thing if we, have a patient with this condition and then, parents just go and kind of make decisions on their own. We're not going to be absorbing that medication. And so if for whatever medical reason, because there are definitely reasons that, kiddos need to be on soy formula or, can only, or they have to take soy-based products, whatever, et cetera, they're just probably going to need an increased dose. And so the provider needs to be made aware of that, because then we're not going to get the therapeutic benefit, right? So our interventions, we'll administer the medication, monitor for side effects. So be thinking like, what are your signs of too much levothyroxine? Hyperthyroid symptoms, right? Like tachycardia, hypertension, hyperthermia, cardiac stress, all that good stuff that you've learned about in farm, right? Mm-hmm. Might need a bowel elimination program if we're dealing with like some serious constipation. So assessment there is crucial. Weighing them, daily weights, and then just regular weights to make sure medication is working. They're able to, start growing and gaining the weight.
When you say bowel elimination program, what is it going to be, like enemas and stuff like that?
Could be, yeah. Definitely could be. With babies, it's kind of, don't like really give babies Miralax or things like that. But yeah, I mean, little suppositories or glycerin, like glycerin suppositories, little glycerin enemas, stuff like that. And then, age appropriate. Because at a certain point, we can take Miralax, but obviously not for babies. Eyes and nose, we get those labs, monitor their levels, make sure they, start trending the way they're supposed to be. TSH, should come down within normal. T3, T4 should, come up to its appropriate levels. And then keeping them warm, we said hypothermia was a sign. So, might need a hat, might need, extra blankets, that kind of thing. And we're going to monitor temperature, a little bit more astutely with these kiddos. And then of course monitoring, for like vital signs and things like that, and then just physical assessment data, hypothyroid symptoms versus hyperthyroid, because we want to bring them back to euthyroid. We don't want to push them over into a hyperthyroid state, because that can be very life-threatening and dangerous as well. All right. Inborn errors is the last one on this one, and we'll take a little break. Thank you for your patience. So inborn errors, your book goes over like a couple very specific ones. I'm going to lecture it like as this like overarching umbrella term, because there's like 50 million of them. And you'll get a kid if you work peds, you will get a kid and be like, they have this metabolic syndrome, and you're going to be like, I have never heard of this in my whole entire life. Like, I think we've dealt with that a couple of times in clinical already. I won't sit here and lie to you and tell you I know every single one of them. And I'm sure Miss Harrell and Dr. Wood are shaking their head yes as well. There's a bunch of them. It's okay to Google them. They're all very complex. So I'm just going to lecture it kind of like as this overarching term, inborn errors. And then of course, you do your own individual research in practice if you work peds, to better take care of and learn about, whatever the condition is that the kiddo that you're taking care of has. So these are congenital metabolic disorders. So they're, our etiology is genetic. And patho-wise, we've got either an absence or an abnormality in an enzyme or a cofactor, or, some very little intricate small part of the metabolic process that results in too much of a certain substance or not enough of a certain substance that our body either needs or doesn't need. Typically, we see these inherited in an autosomal recessive pattern, and they're very important to identify before the reproductive years, so they can be treated if it's something that, we can treat.
So can you screen for it like when they're in the womb, or is it only when they're born?
So usually these, you're not going to know about until either it's going to hopefully screen positive on the PKU, the newborn screen, if it's something that we're screening for, or we start to see certain signs, just like kind of weird, manifestations that we'll talk about. And then that triggers us to draw some baseline labs. Those will likely, some things will come back elevated that shouldn't be, and then we get referred to a pediatric endocrinologist, possibly even, for genetic testing, things like that. Yeah. But yeah, so we want to identify them before the reproductive years, because if this is, a patient that gets pregnant and they've got elevated levels of a certain substance in their body that's toxic, we can see issues with baby, right? It can harm baby, if not cause, potentially like recurrent miscarriages, fetal demises, things like that. So definitely want to catch it. And it can affect, like I said, a lot of, different metabolites. So some of them affect amino acids, some of them affect, fatty acids or carbs or vitamins, proteins, all kinds of stuff. Honestly, like I said, there are so many of them, and they're all, kind of different. I think we had a kiddo, we actually had like a prune belly baby this week in clinical. So one of the things, we looked it up, and he actually had like the syndrome he had, he, doesn't manufacture this protein that he needs. Like that would be an inborn error, like that is technically a metabolic, disorder. And so then he's got this slew of other things because of, the one protein that he doesn't make, or he can't do whatever he needs to do with that protein. So it's kind of like a domino effect. It's kind of freaky. Manifestations can vary, and honestly, they can include every organ system. Typically, neuro and GI manifestations are the most common. We can see vomiting with resulting dehydration that can actually progress to shock. and can they'll frequently be like neurologically altered or lethargic. They can go into a coma depending on what, what there's too much of, what there's not enough of. Hypoglycemia, growth delays. That can turn into like a failure to thrive kind of situation, through no one's fault. Just, we're doing all the things right. The body just can't use what it needs to use to grow and develop. Hepatomegaly. So think of the liver as like the storage unit. You pay for like storage units. Think of the liver as a storage unit of the body. Like anything, if there's like extra, a lot of times the body will like, okay, let's just put this in the liver. And so you can see hepatomegaly because of that. Muscle weakness. We talked about developmental delays. Seizures are really big. And actually, if you have a kid that's admitted for seizures and like neurologically, like epileptically, they get cleared, but we're still having seizures, a lot of times this is the next thing that they're going to start working them up for, is a metabolic disorder, to see if that's what's causing the seizures. Jaundice, overall syndromic features. So certain, think Down syndrome. Those kiddos typically look, very characteristic, right? Like they have the low set ears, their little eyes are kind of spaced out, their tongue is a little bit bigger. Those are syndromic features characteristic of trisomy 21. A lot of different, syndromes and metabolic disorders will have kind of like syndromic features. And sometimes it's, not super specific, but you can just look at a kid and you're like, you're real cute, but something's not quite right. Abnormal odors, so abnormal body odors, abnormal urine odors. We talked about newborn screening, but again, it's not fail-proof, because what newborn screening is basically doing is testing for elevated levels of something in the blood. Well, these are metabolic disorders. So if the baby has not taken in enough oral intake, so maybe we're breastfeeding and it's not going great, and so the baby hasn't taken in a whole lot orally for metabolism to have taken effect, and things, like metabolites to rise up high enough in their bloodstream to pop positive on that screening, they can have one of these disorders, but not screen positive for it because they haven't had enough like carb load, if that makes sense. Like they haven't had enough like oral intake for the metabolism to work enough for, maybe like elevated ammonia levels to screen positive on that screening. So like I said, not fail proof. And therapy wise, there's a lot of labs. Like if you are dealing with a kid that's getting worked up for, inborn error, it's a lot of labs. So baseline, I've listed them for you. And you're like, holy cow, that's baseline? Yes. Yes, that's typically baseline. And then based on the results of these things, and so some of these should look, kind of familiar, right? Like lactate and like pyruvate, think back to like high school biology. These are all like metabolic things, right? These are all things that our body, like within the mitochondria, like things are doing things and it's making energy for us. Like all that really does happen. And if it doesn't do it right, it really does, like there are diseases that deal with that. So based on the results of these, like baseline labs that come back, then the endocrinologist can kind of differentiate, okay, we're probably dealing more with this, or I need additional testing, like let's get this, and this. And so these are usually send-off labs. You wait forever for them to come back, which is hard for the parent. And then treatment, if there is a treatment, a lot of the times it's going to be diet modification. And so in an infant, this is going to translate to a special formula. And unfortunately, it might be a situation where exclusively breastfeeding is not possible. There are also lab levels to monitor. Like I said, we talked about those. And then genetic counseling is something that needs to be looked into for the family.
Could you still at home breastfeeding?
It really just depends. So the question was could you do both? Could you do specialized formula and breastfeeding? It depends. And it just depends if there's something in the breast milk that the baby will not be able to, break down. Is there a protein that they can't break down? And that's going to result in toxic levels of something in their circulation. So then at that point, no. At that point, no, we don't want to do that.
Commissioner Fair,
Yes, ma'am.
this is Robin. I thought you that I throw in there, we need to make sure that they're tested after 24 hours because they have to ingest
Yes.
the protein in order to have the enzymes build up in the brain.
Yes. Thank you.
Has to be tested after 24.
So like I said, this is normally the newborn screen is typically done before discharge, but like she said, after at least 24 hours. And hopefully at that point they've had enough carb, protein, they've had enough metabolic challenge, if you will, for those levels to build up and screen positive. But again, uncomplicated vaginal delivery, they send them home 24 hours. Everything's going good, you're not bleeding to death, baby's doing good, to the house. Again, first time mom, breastfeeding's not going well. Baby hasn't taken in enough, but we're still discharged. There are cracks we can fall through. Okay, so you do not have to memorize everything on this slide, of course, just to show you there's a bunch of them. There's a bunch of them. Sickle cell is actually one of them. Our exemplar that I do want you to learn specifically about is going to be phenylketonuria. Odds are if NCLEX asked you about one, it would be that one. But there are a bunch of them. Cystic fibrosis, maple syrup urine disease, where it actually smells like maple syrup. That doesn't sound like a very bad problem. But then you can look at this picture. So this is an infant with galactosemia, but was not diagnosed until 48 days of life. So at this point, he's already developed cataracts. He's failure to thrive. Look, I know he doesn't, it's kind of hard to see, but look how scrawny he is. His belly is absolutely massive. So he's got, probably ascites, hepatomegaly, all the little muscle wasting, scrotal edema. I'm going to have to take this timer off because it's making me really frustrated. So again, PKU, phenylketonuria. This will be our exemplar. The big thing with this is no protein, no meat, no dairy, no beans, no nuts, no eggs.
So, well, what can they eat?
She said, well, what can they eat?
Cereals, fruits, and vegetables.
Right. Not protein. So then, we said diet modification is going to be huge in babies. That's specialized formula. So you can see, this picture here is phenol free. So it's phenylalanine free because that is the protein toxic levels of phenylalanine, which is an amino acid build up in the brain, which normally isn't, our body normally deals with it. It converts it to something else. And then eliminates it from our body. But in PKU, they lack the enzyme to do that. So it builds up to toxic levels and it can cause, all these issues. So they need this formula. They can't just grab some infantile neuropro. They can't do that. So these kiddos, typically the parents, these patients, the parent comes in with the formula. This is not something we stock in central supply in the hospital, right? If they don't bring this formula, we're in trouble. And so you'll find they are very particular about the formula. Most of the time they're very good about this, and mixing instructions and things. A lot of the times, we're going to follow the parent's lead because that comes very specific from endocrine. That comes very specific from a dietitian a lot of the times as well. Just because this is a different nutritional situation, but we still want this baby to get all the things they need growth and development wise as much as we can. And then this is a different formula as well. Glutarex. So this is, one for one of the other inborn errors, just to give you examples. And then this is a little picture of the newborn screen. So you can see they do a little heel stick and then bleed the baby out basically onto these little circles. And that gets into the state lab. They do all the testing. And hopefully, hopefully we don't screen positive or anything, but, if we have something, hopefully we do.
So do you have to buy that from the doctor?
I'm honestly, Dr. Wood, do you know,
Is it?
I don't know what the ordering process for
Okay.
this is. Like, I do think, like, I think it's like we have to have a prescription situation. Right. Like, it's not like we don't go to Walmart and buy phenol free. Like, or Gluterex. Do you know, Dr. Wood?
No, I really don't. I think it probably would have to be a prescription.
I do think it's a prescription situation. I just know we've been in situations where like the parent doesn't have it or run out, and like that's a whole problem. It's a whole problem. Okay, guys, let's take a 5-minute break and we'll come back. All right.
Okay,
Let's get back to it.
Okay.
Let's get back to it. So we're almost feeling skeletal now. We'll start with PD differences. So bones are more porous in kids. Ossification kind of happens continuously until honestly into the 20s. So nutrition is going to be paramount, right? Calcium. We need calcium to make our bones strong. But this results in easier breaking, honestly, easier bending. A lot of times their bones will bend more before they break. And easier trauma. So think back, learned about fractures in second level. We typically will see higher incidence of green stick fractures because their bones will just bend till, then they break. But good thing is they've got a greater blood supply to their bones than adults do. So a lot of times those breaks will heal faster. But that can kind of be a catch-22. Because if we have a break that, we don't really get set in time and then it starts healing and, then we've got malunion and things like that. So kind of a catch-22. But, greater blood supply typically will heal faster. Ligaments and tendons are stronger than bones until about puberty. And remember, anatomically, we have skull bones that are not fused together at birth. So those spaces are called sutures. Typically, those sutures close around age 2. Dr. Wood will talk about a condition called craniosynostosis, which is when the sutures fuse prematurely. Why do we think that might be a problem?
The head's still growing.
Right, brain growth. Cute little toddlers with a big old head. It's because their brain has to grow, right? Brain grows exponentially in the first couple years of life. And if it doesn't have room to, then it can't. We have fontanelles. Those typically, the posterior typically closes between 2 to 3 months, and then the anterior typically between 12 and 24 months. So that's always part of our assessment, because if they close prematurely, we don't like that either. Growth plate injuries are a thing, because the growth plates are still open in kids, right? We don't super worry about this in adults because they're already closed, but in kids they're open. And so if we damage those growth plates, it can cause, like permanent growth abnormality for those bones. Just like we talked about in trauma, we get x-ray, see fractures in multiple different stages of healing. That's a really big red flag. So this picture at the bottom right, got rib fractures. And again, skull fractures, long bone fractures, spiral fractures. These are all red flags for abuse. Less depressingly, flat feet are usually normal until kiddos are about 6. And then genoverum and genovalgum. So this is bow leg and knock knees. So cute. And I have pictures of these on the next slide. But so genoverum can be, it's usually normal till about 2. And usually, like, parents get very upset about this. They're like, oh my goodness, what is wrong with my child's legs? Well, then they start walking and they start bearing weight on the joints, and everything usually, kind of straightens out. So usually it's a non-problem. And then genovalgum, which is knock knees, can be normal until about school age, or 6, 7. And then walking pigeon-toed can also be normal. Kids just do weird stuff. They do. And it's frustrating because it's like, it could be normal, but then it also could be this. They just like to stress us out. So as we talk about musculoskeletal disorders, they can be congenital or they can be acquired, genetic in nature, or idiopathic, meaning we have no idea. They can also be caused by trauma. And then table 28.1 in your book goes over just some, like baseline, basic assessment stuff. So be sure to review that. We'll talk about specific stuff as we go through each disorder as usual. And then it's got, all the nursing intervention little section. Make sure you're reading about that as well. Please be sure to review, the different tractions, cast care, all that good stuff. We want you to pull that up from second level. So here's genoverum and genovalgum. So very quickly, I want to touch on osteogenesis imperfecta, or OI. It's kind of rare, but we do see, I know, got multiple kids in the Sinlaw area. I'm not too sure about here, but I know I've definitely taken care of kids in Ellick and Shreveport with OI. So it is genetic in etiology. It results in too little or poor quality of collagen. There's various types, and they kind of differ in presentation. Some are more severe than others. I've got a picture on the next slide that kind of goes through the different types. Type 1 is the most common. These kiddos, or these patients in general, fracture very easily. So once they start walking, they just fracture very easily. So we'll see the hallmark signs of fracture. So swelling, pain, bruising. They don't want to move that extremity or joint. They don't want to use it. They don't want to move it. They're also typically shorter in stature, very shorter in stature. And then other collagen things, so their sclera, the white part of their eyes, takes on kind of a blue hue. And then their teeth can be kind of like pearlescent almost like translucent. You can see that in that picture, because then your teeth are bones, right? Your teeth are going to have collagen in them. And then also we can see hearing loss, because don't forget you have those little 3 little bones. Yes, what is it? Incus? Yes, malleus, incus, and stapes. What a nerd, Emily. Golly.
Know that.
What a nerd. I love it. But yes, those are bones, right? And so they'll be affected as well. So then it can negatively affect the patient's hearing. And then waddling gait and very, very bowed legs. Assessment, usually physical assessment's a dead giveaway. They can do skin biopsies, ultimately genetic testing, and then x-rays will be very indicative as well. This is a situation where, you're probably going to see past fractures on x-ray, right? We still want to make sure everything's good, but in this instance, it might not necessarily mean the kid's being abused, right? It's just, I mean, we can break bones with osteogenesis patients, just changing a diaper. It's, you know, in some instances, it's very easy. So our interventions, care is typically palliative. There's no cure for this, but we want to maximize everything, OT, PT, all the T's. Get mobility aids on board. There are surgical procedures they can do for, you know, bone straightening and strengthening.
So you didn't just take collagen supplements to help with?
Medication wise, we might see them be on biphosphonates. So like, is it Fosamax? So usually the meds you see, you know, the little old ladies with osteoporosis on. And your book has the pharmacy 28.1 if you need to review the side effects of those. And we want to collaborate with the doctor, as always, of course, but care can look differently for these kids. Because when I'm telling you, like taking their blood pressure could break a bone, I'm not exaggerating. Diaper changes. Yes, we have to be very, very, very careful with these kiddos. So, you know, we might see care be a little bit different. You know, maybe we do a blood pressure once a shift. You know, so we very carefully have to evaluate like risk versus benefit with these kiddos. So think of CPR. I've actually been in this situation in Shreveport where we have an OI kiddo and he's just, I don't know, needed some extra attention at 5:45 in the morning. I don't know. And just, you know, trying to die. And so I'm looking, you know, at the nurse I'm working with and I'm just like, do we start compressions? I don't want to, you know, like, I don't want to kill him. I don't want to kill him by trying to save his life. And so these are things we have to think about, you know. Of course we try to save his life, but we kind of chemically coded, you know, in that situation. And thankfully he got his life together and came. So we didn't have to actually do compressions, but you know, this is a situation where, I mean, you're gonna break bones doing CPR just in general a lot of the times, but with OI, you know, I can kill you doing CPR. I don't want to do that. I want to save your life, but I don't want to kill you trying to save your life. So nursing management, promote non-weight bearing, low impact activities, and then proper handling, like I said. So, you know, how do we normally, like, we change a baby's diaper?
Yeah.
Right? Like hang them upside. We don't want to do that. You know, we don't want to pull them up. You know, we don't lift them by their legs. You know, lift them by their butt. Be very careful. And then we don't want to be, you know, yanking on their arms, and more so parents, right? You know, yanking on their arms to pull them up. You know, do the right thing. Put your hands under their little armpits. Lift them by their trunk. Don't yank on them because you'll break them. They're fragile. So here's the different types. So some very severe, right? Clubfoot. Technical term, Felipe's equinovarus. Can be congenital, syndromic, positional. You'll see positional a lot. Freaks kids out. Or not kids, freaks parents out. But again, a lot of times once they start bearing weight on, you know, that joint, it straightens everything out. My second little boy, I was like, do you have clubfoot? What is wrong with you? But it was just once he started walking, it straightened out. So this is a deformity of the ankle and foot bones that results in contractures. We talked about it can be syndromic, so like spina bifida, the different trisomies and other like neuromuscular conditions we can see this with. But then we said positional as well. So higher incidence in breech babies, and I have a picture that'll show you why. And if there's any like uterine abnormalities, so maybe mom has like fibroids and, you know, there's something in the uterus that's like putting pressure, you know, or keeping, you know, the ankle and the foot like in a strange anatomical position, or amniotic bands. where there's like bands of amniotic tissue that'll wrap around the extremities of the baby in utero. Low levels of amniotic fluid because there's not as much to float around in, right? Keeps them more cramped, can keep things in strange positions anatomically. And then for the same reason, multiples, so twins, triplets, more than that. There's less room in the end, less room for everybody to stretch out. Presentation, there's also different types of this. I have a picture on the next slide. You do not have to memorize them by any means. Assessment, it is something sometimes we can see in severe cases on ultrasound prenatally, so we can kind of be prepared. But if not, we've usually got obvious assessment findings after birth, very limited, mobility, limited flexibility of that joint. Interventions are going to be serial casting. So usually 1 to 2 times a week for several months. You can see a picture. Those are not actual children's legs. Kind of freaky looking, but it's, just a good picture. It shows like the progression. And then also weekly stretching and manipulation, so they'll take the cast off, PT can stretch it, manipulate all the tendons and ligaments and everything, and then they'll recast. If that's not successful, there are surgical procedures they can do, they can release tendons and stuff like that. And then there's also specialized shoes and braces that they'll wear, after casting or maybe after surgery. You can see that Dennis Brown bar right there. It's cute. It looks like a little snowboard. And then ultimately, if, less invasive interventions fail, then they can do complete surgical reconstruction. But obviously, we don't jump to that. We don't have to. Our nursing management definitely encourage bonding anytime we have, an abnormality. Like I think it was Miss Harrell that said, everybody with the cleft babies, everybody wants that quote perfect unquote Gerber baby. But sometimes life's like a box of chocolates. But it's still a perfect baby. We still love it. We still bond with it. We still put bows on them. We still do all the things.
Does it cause like long-term issues or no? They're just fine after that.
If we've got like an underlying syndrome, then we deal with like all that. But like there's some, like I said, my second little boy, I have pictures of him at a year old and his feet are still, and I'm like, sir. But once he started, walking more and bearing weight, they straightened out. So if it's just like isolated clubfoot, then, certainly there are instances where we don't have any residual issues. So other interventions or, other nursing management, neurovascular checks after, casting and things like that, definitely after surgery. Cast care. As always, we want to promote developmental care. It can result in delays. This little nugget with the Dennis Brown bar. He's going to have a hard time rolling over as much as he wants to. So we want to help them still meet all their stuff. And then your usual post-op care, monitoring for infection, all that good stuff, pain management. So you can see just positional clubfoot, term baby, we're running out of room. Things are kept in very strange angles. And so it doesn't always, things don't just pop right, back to the way they're supposed to after delivery. Sometimes it takes a little time. And then all the different types of clubfoot. Okay, so parent of this precious little 3-month-old nugget says, calls pediatrician's office or, pediatric orthopedics office and says, we were recasted this morning. And ever since she's been restless, refusing to eat and crying inconsolably. Her's cute. All her casts and her little Dennis Brown bar. Oh my goodness. So, what do we think's going on?
Too tight.
Too tight.
Yeah.
Right. So probably stuck between like, is this normal post-procedure discomfort? Because the whole point of casting is to stretch, right? Like, going to be uncomfortable. Or is it neurovascular compromise? So, what are some things that mom said that she was doing that you didn't like?
Not
Refusing to eat.
Don't like.
Inconsolable.
Right. So, not eating and inconsolable, right? Babies are very orally fixated, right? Eating everything makes them very happy. So, when a baby doesn't want to eat, that's a problem. And then inconsolability is also a signal that something's not right. Okay. So, what do we want to do?
Notify provider for sure, I'd say, huh?
Okay.
I would say elevate the extremity.
So, if we elevate, what does elevation do to circulation?
Yeah, so we're already
But
going
if-
in that she's down there.
The only thing that would make me worry with that is if it's like too tight, like we said, and if they, being a baby, I mean, they probably won't get clogged, still it could
Yeah. that's-
dislodge, couldn't it?
So, we're already worried about neurovascular compromise.
Yeah, so then
Right. So, if we elevate, that's going to further impede circulation. So, if we're in a neurovascular compromised situation, we want to keep it like neutral position,
So
flat.
flat.
Okay. So, why wouldn't I tell her to give Tylenol?
You don't give it as kids, or not normally, you don't want to. right?
But you know, maybe something. Cause like, I feel like if you don't know, then don't give it.
Yeah.
Like,
So if I give Tylenol and that like masks the pain for a little while, but
It could be something greater.
I don't address the underlying issue,
you
to make it
Let's
worse,
fix yeah, say something.
right? Yeah. So let's fix the problem. Definitely want to treat her pain, but if I can only choose two, I definitely need to let the provider know, and I definitely want to keep that in a neutral, like circulatory position.
Just question though, what do you mean by scratching cast? Like
Like
cut the
sticking
cast
something
open?
in there?
Or-
Shoving
Oh,
something
okay,
in
yeah,
there.
that's definitely a no.
Yeah.
Okay.
Okay. And then we definitely want to monitor cap refill and the pulse, right? Yes.
so are we going with neurovascular now?
Yes, we are worried about neurovascular compromise. Yes. So like regular normal post-op, like perfusion's good. We have just normal post-op swelling, yes, we can elevate. That's appropriate. But if I'm worried that neurovascularly, it's not, like something's wrong, circulation is not good to this extremity, I don't want to make the situation worse by elevating. All right, congenital dysplasia of the hip. Cause is unknown. There are risk factors. So being female, family history. I know, love that word. Love that. Sorry, ladies. Female family history, firstborn babies.
Okay.
Those that are breech, vaginal deliveries, again with the low levels of amniotic fluid. And then patients with other neuromuscular conditions like cerebral palsy, things like that. So our patho here, we have abnormal development of the hip structures. So you can see in that picture at the top right, on the left, there's a normal, hip socket. The head of the femur rests in that acetabulum. It's the technical term for that part of the hip, right? Whereas on the right, we have developmental dysplasia of the hip, where you can see the head of the femur has migrated out. And remember, like joints are not like just cartilage. Like there's like tendons and ligaments and blood vessels and things like that. So, as the head of that femur migrates up abnormally, it's putting pressure on all that. So this can cause like, neurovascular compromise. It can cause bone, like bone death, infection, all these kinds of things. It's not a good situation. Our presentation, lots of asymmetry. So I didn't give you the picture of the baby booty just for fun. It's cute, but so we have asymmetrical thigh folds, right? The lengths of our legs are probably going to be unequal. One's going to be longer than the other. The perineum can look abnormally wide just because the head of the femur has popped out, making it look wider on that side. We typically see limited abduction. So adduction, ADD, is when you bring it closer to the center of your body. Abduction, AB, as in boy, is away from your body. So limited abduction. And then older kiddos might walk on their toes, especially on the longer leg, because it's longer, right? So everything's thrown off, and walk with a limp. And then we'll talk about the Ortolani and Barlow sign on the next slide. Assessment, this is something we screen for at birth. You'll see when you go to OB and B term, the providers do the Ortolani and Barlow's test to screen for developmental hip dysplasia. And this is usually something they should be doing until the kid's like 2 years old, at all of those little, newborn checks and wellness checks and all that good stuff. And if it does, if they are suspecting something screens positive, they'll order ultrasound. We can also get x-rays or MRIs. And then our treatment plan depends on the patient's age and the extent of the dysplasia. I know it's 12, I'm trying to hurry. So they'll use things, something called a metabolic harness. I have pictures of all of these. Or hip abduction braces. These have to be worn 24 hours a day for 3 to 4 months. Might also see Bryant's traction used pre-surgically or just trying to stretch that tendon. So Bryant's traction, it's the one where it holds the legs up like this. I have a picture as well. And then in certain cases, they might, have to opt for just close reduction, like surgical close reduction under general anesthesia. We see spica casting done very frequently with these kiddos post-operatively. They can also do open reduction. So again, take them to the OR, basically cut that, joint open, reduce it, fix the bones, fix the tendons. And then we definitely see spica casting for weeks and weeks after that. So our nursing management here, we have priority care concepts 28.3, goes over traction and different, the care for the different types of traction. So again, neurovascular and skin integrity checks are huge. We want to educate the parents. They don't need to be adjusting the straps on that metabolic harness. That's kind of like an ordered thing. Maintain the traction and prescribed alignment if they're in traction. Pain control's huge. If they have like a big surgery with this, a lot of times they'll come back. Like we've gotten them in PICU and, they'll have a PCA or they might even, like keep them with a epidural or something because it's a very big surgery. With the spica cast, we'll do a waterproof barrier around the diaper area just because they do have a, it has a little cutout, especially if it's a bilateral spica, it'll have a cutout for the diaper area, but we obviously don't want to get TT and poo-poo on a new cast, right? You're going to have a really mad surgeon. And so we'll put, like a waterproof barrier or something to, keep it from getting yucky. And with the spica cast, they'll have what's called an abduction bar. So a bar like fixed in the cast that keeps their, hips in an abducted position. That's not for you to grab and flip-flop the patient and help pull the patient up. That's a big no-no. Tell the parents too. We'll watch for our normal post-op complications. So all the things you've learned about in adults, atelectasis, ileus, infection, all that stuff still still holds true. We talked about cast care, and then compartment syndrome. So all that should be reviewed, right? Musculoskeletal review. It still happens in kids. So here's cutesy. Okay, so last thing, Barlow's. So with these are the screening tests for developmental hip dysplasia. So with Barlow's, you adduct and push down posteriorly. So you can see at the top, he's adducting. Hold on, give me my pointer. Adducting, so towards the center of the body, and then I'm going to push down. So the whole point is, if it's an unstable hip, they're trying to dislocate it. The provider is trying to dislocate it. This is not something that you need to do, because if you pop a hip out, you need to be trained on how to pop it back in. And I'm not teaching anybody how to pop hips back in clinical. So, and I've got a YouTube video here linked, and I like the way he describes it. Like you go out to the bar. So Barlow's maneuver, the point is to pop the hip out. Whereas Ortolani, if you choose to go to the bar, Ortolani, it's popped out. And so once you go out to the bar, you need to come back in. And so then to pop the hip back in, they kind of use their like pointer fingers and put like upward pressure. And then as they abduct away from the patient's body, they kind of push up to try to pop the hip back in. So the video is really good. It gives it like, in a little animation in real time. And so definitely check that out if you need to. And this is just another to help you remember. And then just pictures, spica cast, Pavlik harness with Pavlik pants. I'm sure courtesy of Etsy. And then, so this is a breech baby.
That's how they come out.
Their legs do that automatically. But you can see it, that puts a lot of stress on the hips, right? So that's why that would be a risk factor there. And then this little nugget, 3 spica casts, 4 surgeries, 105 days. And tonight I get to have a bath. So.
Wait, so how do you make them?
Don't forget the little things. Sponge bath. Got a cast.
Yeah, that sounds
A whole spica cast.
good.
Okay. I'm going to stop there. Thank you so much for hanging with me for an extra couple of minutes. As usual, if I didn't get to it, I won't test you on it. But it still exists in real life. So. Holler. Message me if you need. Have a great weekend.